All right, everybody. Good afternoon. And as Michael, I would like to express my gratitude for being invited to this very honorable session on honoring Clyde Hertzman's legacy. I haven't worked as close with him as you have, and the things I'm going to present still relates to a lot of the things that he was doing. And I'm going to talk about welfare states and health inequalities. But again, as you, Michael, the work I'm going to present is very much the result of concerted actions, collaborations of various sorts, where a lot of the things I'm going to show I haven't done personally, but I've led different working groups and other efforts to pursue this issue of welfare states and health inequalities. Now, to start, what about health inequalities? We know that health inequalities exist in all countries where we have bothered to look, all regions where we have bothered to look. However, these inequalities in mortality and inequalities in health across different aspects of socioeconomic status, educational groups is a very common way to measure it, but social classes, income or other means to measure it. These inequalities, they differ in size and shape. And if you look at the European example, we have a picture where Northern and Western Europe have roughly the similar size of inequalities. It's a graded scale from low-educated people having the highest mortality and worst health to the high-educated people having the lowest mortality and best health. Whereas in the south of Europe, perhaps somewhat surprisingly, there are smaller inequalities. But we also have an east-west divide, where countries, the Central European countries, former Soviet Union republics and Eastern Bloc countries have much higher levels of mortality and much larger inequalities. But there are more to it than that. There are differences between countries in how much the inequalities vary. So if you look at if you compare low-educated people across Europe, the country variation is much larger than if you look at high-educated people. And to me, this says something about the importance of context, importance of the social and policy context in which people live. So what I'm going to try to show to you in this brief 20 minutes is that while there may be not very clearly and very evidently welfare state patterns, it's not the case, for example, that the Nordic welfare states do very much better in terms of health inequalities. There are still theoretical and empirical established links between welfare policies and health inequalities. And this is a research field in development, but I'm going to show some of the latest work that I've been involved in. So starting with theory, why would we think in the first place that there would be a link between welfare states and health inequalities? Well, for a start, I think some of the theoretical, the sociologists in the room might think that it's too much to call the social determinants of health perspective a theory. But there are theoretical perspectives out there, and the social determinants of health perspective is one, very important, being launched by Michael Marmot and his colleagues in several reviews. And they focus on resources and the resources that people possess in one way or another. So, for example, Michael Marmot and others wrote in 2012 that health inequities arise from the conditions in which people are born, grow, live, work, and age. And inequities in power, money, and resources that gave rise to these conditions of life. So it's different stages of the life course, and there are different aspects of resources, power, money, and other resources, that makes up health inequalities in this view. Another perspective is the fundamental cause perspective. You could have some thoughts about the usefulness of that perspective, but there's a sound basis of resources that is put very clearly here. And then this is a quotation from Phelan et al. From 2010, saying that individuals and groups deploy resources to avoid risks and adopt productive strategies. Key resources such as knowledge, money, power, prestige, and beneficial social connections can be used no matter what the risk and protective factors are in a given circumstance. So resources, and there are other ways I can discuss resources, but resources are central to health inequalities. So we would assume then that the size of health inequalities should be linked to the distribution of a social strata of such key resources necessary to lead a good life. And that would include, obviously, childhood conditions and education. It would include incomes and economic resources. It would include working conditions, housing conditions, healthcare, and a lot more. In addition to that, we would assume that differences between strata in human actions and behaviors of the life course is also playing a crucial role. So the perception and interpretation that people make and the actions that they take in times of difficulties, for example, would play a role. And specific health-related behaviors, of course. And if you think of it, all of these factors may, in one way or another, be affected by different kinds of policies that are often going under the collective name of the welfare state. Because the welfare state also adds resources to people. There are individual resources, of course, the resources that people, persons, and families are generating in the labor market that they bring with them in terms of skills or possessions and other types of resources. But there are what we can call collective resources that are provided by different types of policies. And these collective resources, they will assist with the collective matters that arise from the demands and possibilities that all individuals in all societies are facing during their life cycle. Turning that into something more intelligible, we are all facing the problems in raising kids, in making a living for ourselves, taking care of old age parents, and there are all of other things, trying to survive when you become sick and don't have the ability to work, all kinds of things that we are struggling with over the life course. And here the collective resources can come in and assist. And these collective resources, of course, include what we can call the catch side of the welfare state, predominantly social insurances that cover income loss due to, for example, illness, unemployment, and old age, but there are also family policies and other things, other types of policies that are basically cash redistributions. But there is also the care side, and that might be even more important in terms of protecting and redistributing the possibilities of life that Michael was just showing. That is the welfare services that are provided free of charge or heavily subsidized. For example, childcare, healthcare, care for the old and disabled, and educational services that are provided in different ways and in different fashions and in different amounts by different states, and hence providing different sets of resources in different countries. So I think it's reasonable to assume that the resources that can be deployed to lead a good life and avoid health problems are supplied also through the welfare state, not only by the individuals themselves. And hence, you could summarize this sort of theoretical argument by saying that the supply and quality of collective resources are important for people's possibilities to sustain health and well-being, and in particular so when other resources are small, meaning that if your own resources are not enough, if you're unemployed and cannot make a living by yourself, then it becomes essential to have good unemployment protection. But not only then, it is also when you have an occupation, if you do make a living by yourself, it's important to know that if something happens, you would become protected. So countries with more ambitious welfare policies could be expected to have better health, but also smaller inequalities, since the worst off should benefit most. So this is sort of the theoretical rationale behind what we have been doing and looking at. Now, so far this sounds fairly plausible, but what does the data say? What does the research say on this? There has been actually a growing body of research trying to link welfare states, social policies, or policy packages of various kinds to health and health inequalities. Actually, some kind of exponential growth in this this type of research. However, if you look at the data, or look at the publications, you get a very mixed picture. You get different approaches by different researchers, and you get different results. And this is sort of a problematic in many ways, because it's showing that although people use the same notions of, or the same labels of welfare state, you don't get a coherent message when you look at different papers. Some papers show that the Nordic welfare states do better, other papers show that they don't. So what could we expect? We recently made a review, others in this room have made reviews in this field, and the approach that we took was to see, well, is it possible to get more coherent findings if we group the studies that we find out there by the way they have methodologically and theoretically approached the problem? So we see, following other research, we disentangle three main approaches to welfare states, because that's, of course, one of the essential problems, how to capture and measure welfare states' effort. And there are three main approaches. One we call the regime approach. Basically, you try to put together cluster countries according to some idea about a common denominator. So you have just Asping Anderson's seminal work on three worlds of welfare capitalism, for example, denominating the social democratic regime, the liberal, and the conservative regime. And there are other theoretical packages that try to do this same thing on quite different theoretical grounds sometimes, but nevertheless it's a clustering of countries. This is very popular. When we're looking at the papers from 2005 and onwards, we find 34 papers that have a regime approach. There's also an institutional approach, where you try to look at the institutional setups of programs. What the characteristics, what are the legislated rights, how large proportion of the population is covered, how much do they get if in need, etc. And the third approach is the expenditure approach, where you look at the money spent by the welfare state. All these three approaches have their pros and cons, but are kind of distinct in their theoretical and methodological approaches. And as you may have already understood, the regime type of papers are in themselves quite divergent. There are very different types of regimes, different number of countries being included. It matters a lot if you include Eastern European countries or not, etc. So we subdivided those by not only by typology, sort of the theoretical foundation, but also by outcome, by data source, by number of countries, and some other ways. And you will not be able to see this, but you can see the amount of papers, and here you have 4 different regime type groups, and the institutional and the expenditure approach. And as you also can see, it's kind of difficult to compare these 3 approaches, since there are so much more work being done in the regime approach. However, this basic idea we had that if we try to sort them in a good way, then we're going to have coherent results, that actually failed. No matter how we sorted these papers, we couldn't find a very coherent picture. The research assistant who was doing some of this work, in a desperate move, final move, she sorted the papers according to the home country of the first author. And it seemed to us that the more Scandinavian the first author was, the more negative results for Scandinavia were obtained. But we were advised by some reviewers to take out that, because it was a bit speculative. Anyway, it was correct, it was speculative. Anyway, this is sort of what it looked like. And we couldn't find much of sort of systematic differences that could be understandable in the regime approach. On the other hand, the institutional and the expenditure approach did have some coherent results. So the general findings about different approaches that we came up with was basically that the regime approach do not lead us much more forward, which is a bit controversial in this field of research, because a lot of people are using different types of regimes. And I think being very blunt, I think it's very easy to do it. It's easy to have national data lumped together, Sweden and Norway and Denmark, and perhaps some other country, and then Germany and some other country in England and US, and then you have a regime typology, and then you can say something about welfare states. It's much more complicated to dig into expenditure data, and even more complicated to get hold of institutional data. But I think what we have shown is that the regime approach will not take us much further in terms of health inequalities research. And part of the explanation for that is that there are so different, if you include Eastern European countries or not, if you include Southern European countries or not, will alter the whole gameplay in a way that goes far beyond the understanding of the regimes or the theoretical foundation of the regimes. Clustering of countries is too blunt, actually. But the institutional expenditure approaches are more promising. And I will show you some results on both of those. And starting with some work that my Norwegian colleagues did for the WHO European review. This is data based on a number of European countries, the individual data, living conditions data, the EU SILC, but also expenditure data on the national level. So what does it mean for people with low education or high education to live in a context where social expenditure are higher or lower? And as you can see, if you go from small to high, minimum to maximum, health improves in all educational groups, but it improves more for the low educated, thereby contributing to smaller health inequalities. Is this due just to the fact that low-educated people get more benefits? No, actually not, because the same authors did in an earlier paper look at the risk for non-employment. And they divided it by education, but they also divided it by whether you are having a long-standing illness or not. So having a long-standing illness to the left and not having a long-standing illness to the right. And in all cases, it's better to be high educated, it's better to not have a long-standing illness for the risk of non-employment. But as you can see, also for all groups, in settings where social expenditures are higher, we will also have lower risks for non-employment. So social expenditure is not just about the people getting benefits, it's also about how society works. Now, turning to something more about the institutional approach, we have lately been working with unemployment benefits. And there are two important dimensions here, the coverage and the replacement rate. So how big proportion of the population is covered, and what do they get when on unemployment benefits? And what we find is a bit counterintuitive in first. As you see, the two lines here is for high and low educated people, and here it's reversed. It's actually positive health, the probability to have good health. So when replacement rates increase, the probability for good health seems to go down. It's not really statistically significant, but it's not a positive sign. But when coverage go up, then health improves in both groups, but about the same. Underneath this mixed result is actually an interaction. So when we divide countries by the level of coverage and only look at high coverage countries, we see a strong relationship with replacement rates. So here you see that with increasing replacement rates, if coverage is high, health improves much faster among low educated than high educated, thereby closing the gap. And they also, my colleagues at the Swedish Institute for Social Research who did this research also looked at transitions before and after. So it's longitudinal data on individual level before and after the 2008 crisis and the propensity to move into poor health. And again, dividing by low education and high education and the employment coverage rate. So with higher coverage rate, the propensity to move into poor health is much smaller. So some key findings. A general effect of welfare regimes is difficult to establish for not very complicated reasons. But on the other hand, that doesn't may mean that there are no effects of welfare states. There are clear relationships between social protection in terms of social rights and social expenditure for both health levels and health inequalities. And the new findings that we see emerging now suggest that coverage may be even more important than replacement rates, and at least there are interactions going on there. The relationship is often curvilinear, indicating that there is a larger impact of improved social protection at lower levels. And specific programs have effects, but it may be that more extensive social protection that we cover with expenditure may be most important. And drawing some conclusions, some general conclusions from this, I was challenged by Michael Marmot when I was chairing a group for the European Review to come up with some short, catchy phrases. And I think that you can say from these data that policy matters. What we do matters. How we design unemployment insurances and other insurance schemes matters. And in countries where you have nothing, you can actually do something. And in countries where you do something, there is always room for increased coverage and generosity. You can do more. And in those countries who already do a lot, there is plenty of room to do better. Thank you very much.